was not deactivated. So years and years and years go by, and that remains. It doesn't just go away. It doesn't just dissipate, because it's connected to, I have to stay on guard in order to not be hurt. If I'm not on guard, I'm at risk of being hurt. Now we're perpetually on guard. And now we're lacking quality and effective interpersonal connections. And now we're feeling the effects of that. So now we're beginning to feel anxiety. Now we're beginning to feel depression. And lo and behold, when we take a drink or a drug, those feelings disappear. That weight is lifted. My defense mechanisms dissipate. I'm more open socially. I'm feeling connected. This is great. So it's an example of how these pieces can add up and get us to a point where now we're developing a substance dependence issue. Because the cure for our feelings of isolation and loneliness, the cure for our fear of connection that we're not even really aware of, is alcohol or drugs. And we know the cycle of addiction, that's only effective for so long before that begins to backfire, and look at where we end up, usually isolated and alone, and usually feeling more anxious or depressed or whatever it may be than when we started. So that's again, that interconnected theme. But we want to view personality disordered features as an effort to keep people at bay and at arm's distance. Very important when we're talking about a treatment setting, and it's very important when we're talking about involving the family. Right? What message are we sending if we have an identified patient in treatment and the family is disconnected? The issue emerges then that we might be unintentionally reinforcing some of what's getting us into trouble. So we want to at least make that effort to involve the family members. Sometimes we're going to have to make a call, and we're going to have to go a different direction where the focus is primarily maybe on the individual in doing their own work, and then doing some more concerted boundary creation with the family system. That's oftentimes how we have to go, because the family is so entrenched in their defenses that they're not moving. Look at this, family and intergenerational considerations. Okay. We're all connected here. So the early emergence so we have the stress response system activated early if we're not getting some of our basic needs met. And that's done by inconsistency in parenting. It's not major. It's something that the majority of people are going to experience in one form or another. Yes, Tom.
Another question.
Yeah.
It sounds like substance abuse can be a negative reinforcer, in that the substance use results in no longer feeling those negative feelings of depression, anxiety. Is that accurate?
I mean, see, I'm not totally sure. Like, I understand specifically the substance dependence comes into the mix, in a certain sense as an attachment replacement. So a lot of times, and there's studies that talk about this or indicate this, there's a parallel between a person breaking up or losing a relationship and a person coming off of a substance. I think they've done some brain scans where they'll actually show a person, and somebody addicted, a picture of cocaine, they'll show a picture of the spouse. The same areas of the brain light up. So the substance is a safe connection. The dependence on the substance is the first quote unquote healthy attachment for a lot of people, because we've learned that it's unsafe to connect. and to be close to other people. We have some survival mechanisms activated that are keeping us at a distance. We have personality disorder features activated to reinforce that. And then we stumble upon drugs and alcohol, and it provides us with a feeling, provides one with a feeling of comfort, of feeling good. In a perfect world, those feelings would have been elicited by healthier, more meaningful connection and attachment. So when we introduce the substance, it definitely, I'd say it reinforces a person not being motivated to connect to other people, because now we have it sort of locked in our brain that that's our safe place. That's the place we can go to have our needs met. And it certainly makes it more difficult, or I think it makes it more difficult to address the personality features. You have another layer to work toward, or to work through. On the other hand, I guess a silver lining is that the substance issues oftentimes are the things that get a person into treatment. Usually, right? Usually somebody struggling with avoidance and dependence, they're not, in and of themselves, are not going to find themselves in a treatment setting. Usually it's a result of substance dependence. So that's a sort of a, again, silver lining, and that's the thing that gets somebody in to where they can do some of the deeper, more meaningful work, and then develop a skill set that helps them with healthier attachments and undoing some of the defenses that have built up. I hope that answers the question. The family is important for a number of factors, and we've talked about it, right? The family is where we're learning connection. It's where we're learning how to communicate. It's where we're learning that there is such a thing as implicit messages. This is also where, as kids especially, we're absorbing what's around us. And a lot of that is to help us grow and adapt and evolve as quickly as possible. It can be detrimental when some of what we're absorbing, some of what we're taking on, is on the maladaptive end of the spectrum. And that happens. That happens when a parent is substance dependent. That happens when a parent has unresolved family of origin stuff. And this is the vast majority of people. This is not some bad stigmatized thing. This is a result of being human and being raised by other imperfect humans that have been hurt and that have developed ways to respond to hurt. And that's the context that I want to support viewing the family stuff through. It's not that generally speaking, the families, the parents have not done something explicitly malicious. There are those cases. But that's not every case. And we want to support people in understanding that a loved one struggling with a substance issue or depression or anxiety or whatever it may be, yeah, everything's connected here. Yes, there is some stuff that's helpful. There's some stuff that was not helpful. Let's take a look at it. Let's use this as the opportunity, if you're willing, to break that cycle. It's not that easy. Again, because the families are defended and guarded. And again, because this is connected to that survival mechanism, keeping us safe. And that stuff's been around for a long time. It served a good purpose. It's been passed from generation to generation. That's what we're talking about here. Okay, is that not only can trauma, complex trauma, personality issues, defense mechanisms be passed along via experience, via modes of communication and behavior and emotional response, etc. We're also seeing that trauma responses, quote unquote, mental health issues can be, there's a genetic component. There's more and more research being done on humans and animals that validates this. Just look for my information. One example is they found a protein that's responsible for transporting serotonin. I'm not doing this justice, right? They found a protein responsible for transporting serotonin. Serotonin helps us to feel good. It's one of the chemicals that antidepressants target. It's one of the chemicals that's released when we accomplish a goal, when we do something pleasurable. It's pleasurable because it releases serotonin in part. We have identified that there is a gene that, if it's altered, impacts the level of serotonin that a person is able to send through their brain. And we know that is connected to heightened instances of issues like aggressive behavior in Alzheimer's patients, post-traumatic stress disorder, depression, and also susceptibility to experiencing trauma or traumatic response. So not only is there this experiential mode of passing along trauma, we have a very clear-cut genetic component that can certainly predispose individuals to experience more acute mental health issues, substance use issues, etc. Now, this begs the question, why does that happen? And that brings us into a study of what's called epigenetics. And that's the study of whether or not basically genes turn on and off or can be altered based on a person's experience. That I'm not versed enough to really speak on. My understanding is the jury is still out. However, it is something for our line of work to definitely be aware of. Right? Can a person experiencing trauma, stress, etc. in their lifetime alter their genetic makeup? And if so, again, we have this very clear parallel and hereditary element to what we see showing up for people. So it becomes less and less about this sort of nature-nurture debate. It's nature and nurture. And again, we want to have this understanding so that we're supporting family involvement. What is it? Well, what does it mean that so-and-so is predisposed to alcoholism? Well, it's not just that there's a gene there. It's possibly that there have been past experiences that triggered a genetic change. And those experiences have contributed to the development of defense mechanisms that have brought us here. And if we're not all working on it, we're still in the cycle. And we're still operating off of the same family roles that we were pre-substance dependence. And if we're doing that, chances of relapse are higher. It's as simple as that. If the system isn't operating out of a safer place, then we're operating out of that heightened space that triggers a substance dependence down the road. Again, talking about the role of family in early childhood and attachment and development of interpersonal connection. A kid early on is entirely dependent on uh, their loved one and their primary caregivers. So, I think arguably, we're, as a species, I guess we are dependent on a caregiver for longer than maybe any other species. It takes a long time for a human to develop into being self-sufficient. We're looking at essentially over a decade, closer to 2 decades. So there's a very deep connection. This is what I learned my previous agency. There's a deep connection to this dependent position between child and caregiver, and that is a survival mechanism through and through. And so the child will unconsciously take on responsibility for the caregiver's well-being. Because if the caregiver is not okay, the child is not okay. And this makes us very deeply in tune to what's going on with the adults in our world. And so on average, let's say an adult is relatively stable, caregiver is relatively stable. And from time to time, they become angry and there's an outburst. Now, this depends on a lot of different factors, but you know, that can be something that triggers a response, triggers a survival mechanism, triggers something in a person that says, I can't count on the stability of the environment. So I'm gonna stay hyper aware, or I'm gonna try and get, this is one you see a lot, I'm gonna try and get straight A's. Because if I get straight A's and my room is always clean, then they won't have any reason to be angry. And then lo and behold, they're still angry. And now we have somebody that's tried to solve a problem for a caregiver because they are feeling uneasy. That effort has been unsuccessful. So now we tack on a belief. My efforts are not good enough. They're still angry. No matter what I do, this is happening. Right? So now we have somebody that's not only feeling sort of scared, but maybe even helpless because they've made an effort to assuage emotional distress for a caregiver, and it hasn't been effective. So it's not a major trauma, and it's not that the parent is a bad person. Parents are maybe a great parent. But you can see that these implicit small interactions, experiences built up over time can evolve into something. And again, a lot of this is not happening consciously. This is embodied experience, especially when that fight or flight system is triggered, when that nervous system is triggered. That's signals through the body. We're not thinking that through. And so we then have all of these pieces that are sort of stuck, these emotions that are stuck, these beliefs that are stuck. And this is when you get into, or you can get into, parts work or internal family systems or ego states. And this is where, and we'll talk about it a little bit down the road here, this is where you get into issues like disassociation. Not like multiple personality disorder, but dissociation exists along a spectrum and can show up in this way that a person goes back to an earlier place when triggered by anger, for example. I make note of this called the diathesis stress model. And that's basically, it's a model that explains sort of what I'm trying to explain. And it's an effort to look at presenting issues from a multi-factor developmental perspective. Diathesis is a Greek term, and it has to do with vulnerability or disposition. And the theory there, I have a graphic somewhere, but the theory is that a person's predisposition, combined with life stressors, right, will tip them over the edge, per se, into pathology at times. And so the disposition is what we're talking about when we're talking about the intergenerational component. The disposition comes from the inheritance of trauma response patterns via genetics or via experience and interpersonal connection. But again, we can't underestimate the importance of early childhood. And I think we can't underestimate the importance of, pre-memory experience for people. That's going to reinforce getting as much information as you can. If you have the luxury to really dive in and do an assessment with the family, as much information as you can about early childhood experience. I mean, early. You can look at what was going on during the pregnancy as well, because there are studies also that correlate maternal stress during pregnancy with higher rates of mental health issues as well. So that's definitely worth investigating and getting into, because we have concrete data that says there is a connection there. I love this list. It does what it says. It's the scope of trauma as we're understanding it, or as I'm trying to explain it up until this point. And as you see, we're hitting a lot of topics. And all of these factors are interconnected and interwoven and working together to get us where we are with somebody, to get us to that presenting issue. But all of this stuff, right, this is the material that's going on underneath the surface that's getting us to that presenting issue. These are the pieces that we do ourselves a great service in being very aware of. And these are the pieces that we do ourselves a service educating families about as well. Right? We need to know, we need to reinforce that it is not just that your loved one is drinking too much. It's not the deal. That's not the deal. It's important. We don't want them to keep drinking. So, big proponent of sobriety, 100%. But the more that we can support the family in understanding that that's the piece, the better our chances are at engaging a person in long-term recovery. If the family is behind it, our chances are exponentially improved that we can get the patient, the identified patient, behind it, whether they're initially motivated or not. If the family is not behind it, we have an uphill battle. Because the identified patient, if we're working with an identified patient, we're basically saying to them, hey, we need you to do away with your go-to survival mechanisms and start fresh at 40 years old. Whether that person says they're on board or not, their brain's going to be going crazy saying, no, thank you. And because of that, a lot of times we have people attempting every possible escape route. Maybe I can avoid this. Maybe I can do this. Maybe I can try this. What if I do this? What if I lie about this? What if I start this behavior instead of that behavior? Everything. So if we don't have the family firmed up to support us in getting the identified patient where they need to be, right, then the patient has an out. If the patient's able to say, this is crazy, it's just a drinking problem, I'm going to stop drinking. And there is more significant stuff going on for that person. It's not going to turn out well. So the more that we can educate the family that there's this multi-factor understanding, an effort to understand their loved one, and that we want them to adopt that approach, not just for their loved one, but for themselves. We want them to understand themselves so that they can feel better. Our chances improve exponentially. One of the things that sticks with me is, a clinician, that talked about how many times, a patient would overdose in the home of their loved one or their family. And that comes from a place of the loved one and the family being really, really scared usually of what's going to happen if their loved one is not at home. But it illustrates the need to get the family involved and supporting them in doing their work so that we can help the person, the substance dependent person in this instance, begin to stand on their own 2 feet, begin to develop that healthier sense of self, that more adaptive sense of self, to the point that the substance is no longer the necessary go-to to feel okay. So when we talk about the scope of trauma, this gives us some routes for our treatment. And we're talking about a lot of different things here. Attachment, we've discussed, that's early childhood, that's primary caregivers, that's family systems, boundaries, trust, isolation, perception of others. All of this is going into how we connect or how we don't connect. We're talking about biology. Again, breaking up that dichotomy of mind-body. It's all biology. It's all connected. There's a genetic component. There's a neurological component. There's a nervous system component. There's a digestive component. We know now that there are neurons in the brain. If somebody has a gut feeling, that's a real thing. I'm pretty sure that's neurons firing in the stomach. That's a gut feeling. Emotional regulation. This is what we see a lot of times, again, as a primary issue in reference to personality disorders. So that those cluster B features, emotional dysregulation. It's emotional and reactive. Cluster C, anxious and avoidant. Cluster A, we have the paranoia, the fear. So all of these things that show up in our modern understanding of personality features and traits, right, again, come back to that difficulty in regulating the fear system, fight or flight system, and all the emotions that come out of that. Disassociation is very important, and it's something that we're learning more and more about, and the perspective around disassociation is improving as well. It's not dissociative identity disorder. It's not multiple personality disorder. Disassociation exists along a spectrum. Disassociation is also one of our most primitive survival mechanisms. And it's usually something that's triggered by a feeling of helplessness. And it's something that often happens to children because the reality is, when confronted with something scary, a threat, perceived or real, a child does not have a lot of recourse. And so the brain will disconnect, essentially. Again, if we go back to fight, flight, freeze, dissociative element is a bit of a freeze, right? Or even you could say maybe a bit of a flight of conscious awareness. The person's going away. They're there, present, but detaching from their conscious awareness. And again, this exists along the spectrum. So daydreaming is dissociative. Sometimes people will drive in a car, and you won't really remember what you saw and what you were doing between point A and point B. It's dissociative. This happens a lot when you're working directly with trauma memory. It's felt in the body, and you may notice that a person detaches, disconnects, goes away. And there's a variety of different modalities to help keep a person connected and do that kind of work effectively. But it is something to be very much aware of if we're working with if we're doing more strict trauma work. The dissociative element, the emotional regulation element, and the attachment element also brings us into the idea of sort of, you talk about states, ego states, parts work. These are all pieces where we have a propensity to regress in response to certain triggers. And that's an underdeveloped part of one's self. And a lot of times that happens when a person is being triggered and feeling helpless, or if a need is not met. So in a treatment setting, you can get a pretty good read for regression when you say no to somebody. You can get a pretty good read as to where they are on the developmental totem pole. But a lot of times in that treatment setting, somebody wants to go out on a pass, or somebody wants their cell phone, and you say no, they react. And usually it's a bit of a tantrum, or it can be a bit of a tantrum. That's not a coincidence. It's not a coincidence. That's because that no to the cell phone was a trigger. The other element is that there's a manipulative component to it. Right? There's definitely systems where we learn that if I throw enough of a fit, I'm going to get what I want. So again, it's a good tool to have. It's also a good tool in terms of practicing healthy attachment, healthy boundaries, healthy expectations, reciprocity within a relationship. These are all things that support us in helping people develop healthy, meaningful connections. Is that you don't get that just by saying yes to requests. Behavioral and cognitive, behavioral, right? That's going to be our substance dependence is a behavioral issue. That's right? It's along that obsessive compulsive spectrum. Same with cognition, right? Obsessive, an obsession of the mind, ruminating, thinking about something because it has taken on right? It's our go-to safe place. And so it becomes a person's focal point. We also know, in reference to cognition and neuroscience, that there are links between childhood stress and traumatic experience and neurobiological structural issues in a person's brain. So there is impairment in parts of the brain that have to do with memory and emotional regulation. I think hippocampus is one of the biggest ones. Yeah, associated with emotional regulation, and self-concept. When I shared the example about the person, attempting straight A's so that their caregiver parent wouldn't get angry, and that doesn't work. Now their self-concept has been impacted. They've set a goal, they've attempted the goal, they've been unsuccessful in achieving that goal. And really, no matter how hard they try, they're not going to be successful in achieving that goal. That's going to impact a person's self-concept. That's a type of pattern that's not going to, when that person leaves their family system, that attempt is not going to end. That's a person that's going to continue to try and be perfectionistic. That's going to continue to try and get straight A's. That's going to show up in their relationships with significant others. That'll show up in the workplace. You see a lot of the times is that there's a perfectionism, there's a striving for approval, essentially, in effort to regulate that impacted self-concept, that impacted sense of self. And again, right, we can associate OCPD, obsessive compulsive personality disorder. That has to do with perfectionism, in a sense. Talking about, or going back a little bit to fawning, and the relevance of family and the roles that we take and how those develop in the personality features. All of this, again, is under that complex trauma umbrella. But one thing that you see, codependence is another sort of popular term. Well, what is codependence? And one of the best ways that I understand that, I see that show up for other people, is understanding how family roles develop. And a lot of times what will happen is parent comes in and they're feeling sad. And instead of parent, for example, calling a friend, hanging out with some people, doing something enjoyable, cleaning the house, whatever, taking care of their sadness, right? Instead of taking care of the sadness, instead of coping with the sadness in a healthier way, the sadness or the feeling state is put out to the family. So the person comes home and everybody in the family, I don't know if anybody can relate to this or not, right? But everybody in the family can feel the feeling. And maybe you say, hey, what's wrong? And the person says, oh, nothing. But right? Everybody knows that there's something. There's a feeling. And so what happens is the members of the family take on different roles and develop different strategies in an effort to take care of that person's feeling. As a result of that, the sad person isn't learning to cope with their feeling state. And everybody else in the family isn't learning to cope with their feeling state, because now some of how they feel is based on how well they can fulfill a role to take care of somebody else's emotions. And there we have the underpinnings of what becomes codependence. The consequences of that can be significant, because now we have a set of people that require something to take care of. They need to fulfill this role. Their sense of self is connected to this role. And the role can take on a number of different personality disorder traits and characteristics as well. Some people act out. Some people create a distraction. Some people, get themselves arrested. Can't be sad if you're distracted by me getting arrested. Some people avoid and withdraw. Well, I'm not going to do anything to contribute to this person's discomfort. I'm going to just stay out of the way. Or maybe we begin to people please. That's the element of that fawning again. I'm going to ingratiate myself. Do you need anything? What can I do? So all of this stuff can be going on within the family system and can be creating this stress that everybody's responding to and working around, but nobody's learning to take good care of themselves. We're not learning that it's safe to connect. We're not learning that if I share honestly with somebody, they're going to be able to handle it. So I'm not going to share honestly with anybody. And then I'm not going to have quality relationships. And then I'm going to feel isolated and lonely, anxious and depressed. On and on and on we go. Again, this is not blaming of families. It's, we could argue, impossible to not have some of this going on. It's, in a lot of ways, it's okay. It's a part of how we learn about what works and what is effective. We need to know what's not effective. It does become our responsibility, though, when we become aware of it. And that's important. When we become aware of it, and we allow ourselves to do some of this work, our ability to make healthier, more adaptive choices increases. It's not easy, but it increases. And so that's another sort of point to be aware of, is where we want to be a part of the solution and the work, and where are we digging in our heels. If we're digging in our heels, what's the stuck point? Because that means something as well. I mentioned this before, the diathesis stress model, and this is an illustration. We got a couple of cups here. The red illustrating the stress, D1, D2 illustrating the disposition. Yes, sir.
Just gonna jump back. The question is, shouldn't they learn who it is safe to share problems with, since some people cannot handle their problem?
Yeah, yes, for sure. And so I think that's one of the great tools of therapy. Again, is that, I forget who said it. I might have been a presentation I was at, but great presenter, and they said, look, as much as we know, there's much more we do not know. And the reality is, the best thing that we have is talking to another person in terms of treating mental health issues, addiction. Best thing we have is talking to another person. And so treatment, therapy is that. It is in part, amongst other things, developing the therapeutic relationship to a point where our chances of that honest communication, that openness, the practice of that vulnerability is increasing. And so the therapeutic process is that work. How can we be authentic? How can we be honest? And how can we do that safely? And a part of the job of the clinician is to identify, based on all these factors that we're talking about, the unconscious barriers between the person being able to do that. Because again, we have all these layers of defense built up. So on a conscious level, a person's being transparent and honest and totally open, right? Unconsciously, we're still sifting through a lot of different defenses before we're getting to somebody's sort of truth, so to speak. But it's a great question. I think that's one of the best things about treatment, and is that you have just so many opportunities to support a person in developing honest communication. That's a big part of the group work too, is that you fast track vulnerability, and that really helps to override, I think, a lot of defense mechanisms. It's shame reduction. You're able to develop a healthier sense of self. You're able to take a risk. You're able to connect with other people. It also gives you, that group work also gives you a great snapshot of how everybody, how people operate in the family system. You have a primary group that you work with. It's super cliche, but that's your family system. So again, I hope that answers the question. But the practice of honest communication, that's the deal. That's the deal. So this diathesis stress model, we see the disposition D1, D2, the person here with the higher disposition, when the stressor hits, their cup is full. And when that cup is full or overflows, there's the emergence of our pathology. And so, or the personality disorder traits or characteristics, or the substance dependence or whatever, right? Anxiety or depression, whatever it may be. So not only do we want to address the overflow, what's spilled out of the cup, we want to address the stressors, the experiences that trigger these issues. And we want to understand what is the predisposition. And that's going to bring us to the consideration of the family and the family history. A good example of this. A good example of this is, or a classic example is, working with folks that are children or relatives of Holocaust survivors. And that one of the sort of classic examples that's used is because there have been studies that show higher rates of depression and suicidality in the children of Holocaust survivors. Why is that? Why are the children of incredibly resilient survivors having a hard time? And one of the reasons is they've adopted defense mechanisms and strategies that serve the purpose for an extreme experience. But when applied to a different time, a different age, a different place, they don't work. And that leaves a person having a hard time. So, right, the child of the survivor comes home from school and they say, I had a hard day at school. And the parent says, you don't know what a hard day is. You don't know how good you have it. That's true. Parents trying to be helpful. Parent is trying to be supportive. Parent is trying to build up their child. The child says, Well, every time I say something's bad, I get told it's not bad, and I'm not really feeling that supported. So they end up, they stop talking. They stop sharing. And now we have somebody that's going inwards too much. Yes, sir. It's good to see every once in a while, you know.
Oh, I know.
I know at least one person is still here, which is good.
No, there's a good number of folks there,
A
and
good number still hanging in. Okay, wow, boy, oh boy. Okay.
you're doing great.
Oh man, holy mackerel. Yes, sir.
This is going back. Can you describe what the D1 and D2 portions of the cup represent?
Yeah. The D1, D2 is the diathesis. It's the disposition or predisposition or vulnerability that a person has. So somebody going through life with good enough parenting, upbringing, experience, they get hit with a stressor, they still have space in that cup. Somebody that has been exposed to complex trauma, mental health issues, etc., they're maybe predisposed or more vulnerable. They don't have as much space in their cup to manage the stress. So when that stress occurs, the cup overflows. So the D is the person's vulnerability. And why is it that some are more vulnerable than others? In part because of these survival mechanisms that have been inherited and passed down, that are just no longer serving the purpose they were meant to serve. So our example with the Holocaust survivor and their child, the survivor took on a mentality of, you don't know how good you have it, kid. You don't know how good you have it. You had a bad day at school. You don't know how good you have it. You should be grateful. Again, that's healthy. There's nothing wrong with that message. But it can be internalized as, we don't want to hear about your bad day. And that can then be taken on or evolved into something where the person is more shut down or more reserved. They feel like anytime they have an issue, they're complaining. They should be more grateful, etc. And this again is sort of an implicit pattern. It's not something that is necessarily going to be conscious, not something that they're necessarily going to be aware of, but it's going to have an impact. And it's going to have an impact in one way or the other. Maybe not explicitly, but maybe it's adopted, and then their kids, have a hard day at school, and it's the same message. You don't know how bad it could be. Your grandparents went through the war, survived the Holocaust. Don't tell me about a bad day at school. You should be grateful you have school. Again, that definitely be grateful you have school. And we need to support the ability to discuss what we're grateful for and what we're having a hard time with. This is a chart of personality features. This is from the DSM. I think this is from the DSM-4, and it's interesting. They have a little, I don't know if anybody can see it, but they have little asterisks or marks next to some of the personality disorders, and that is proposed for removal in the next edition. And that brings me to, I'm not a huge proponent of over pathologizing and labeling, as this is an example of this stuff is fluid, it's not concrete, our understanding of all these things is changing. The importance of having some understanding of the personality presentation is that it informs our understanding of the family system and some of what the person is possibly coming out of, and it also informs our treatment efforts. So I'm not going to treat a cluster B antisocial the same way that I'm going to treat a cluster C primarily avoidant person. That's not going to be effective. So if I'm not able to identify some of the presentation, some of the groupings, then my treatment's going to be off. So the personality framework is very, very helpful for informing the treatment. What is the goal here? What am I trying to accomplish with my avoidant person? Well, why are they avoidant? How do we get them to be less avoidant? Okay, that's going to be very, very different than working with the cluster B antisocial. Another example is DBT, great modality, great practice, quality program for borderline personality, right? Our personality disorder of the day. Not so great to put the clear-cut antisocial person into a DBT program, because now we may have a super interpersonally effective, mindful, emotionally regulated antisocial person. So somebody that's better able to manipulate, essentially. So you want an awareness of some of these factors. In addition to that, it helps to inform the family system. And another example, and borderline is an example of this, there's something like a 5-time heritability. If somebody's presenting with borderline features, there's a strong chance that somebody in the family is having that. And you can also get to a point where there are it's almost formulaic, that there are certain combinations of personalities that show up that then support the formation of other personality disorder traits and characteristics. Again, I have mental disorder in quotation marks. It's not all mental. It's not. This stuff is deriving from nervous system response, mind, body, all connected. It's all connected. So something that hopefully we'll move away from and get creative with in terms of some of the terminology that we use. As I said, labels can be helpful in terms of collective understanding and treatment purposes. One really critical or helpful piece in terms of understanding personality is, that's the one where somebody's depressed, they go, I'm depressed. If somebody's personality disordered, this is from my previous place of work as well. It's really, really helpful to kind of frame my understanding. That's everybody else is the problem. So rarely when we have the personality issues that the defense is so well defined that the person is not initially identifying their problem spots. And the avoidant person is not going to go, hey, let me jump in the group and tell you how I feel inadequate. The avoidant person is going to go, the group is uncomfortable for me. And that's a really important sort of marker. It's a helpful marker. Well, no, the group is not unhelpful for you. We don't know that. But you're having feelings about engaging in the group. And what is that? How can we work with that? You're going to be met with defense there. No. Only individual sessions. And only do individual sessions. That's one you hear a lot. We'll take it into consideration, but that's right. That's a key marker. Depressed person, again, right? I feel depressed. I feel anxious. When our personality, when we get a layer down and we're dealing with those personality features, it's usually other people, other things are the problem. It's not, we're not identifying, generally speaking, our own personality disordered, quote unquote, traits and characteristics. Again, this stuff exists along a spectrum. So, I hesitate to say somebody has borderline personality disorder or narcissistic personality disorder, avoidant personality disorder. This stuff it is fluid. It's not set. It can be changed. It requires work to change it, but it most definitely can be changed. And so, to give it the clear-cut label diagnosis, again, personally, I hesitate a little bit in doing that. I think a lot of it is along the spectrum. And this is going to sort of bring me to my wrap up, my conclusion here. And this is, I love this graphic. This is from a study where they were looking at the historical, the impact of significant historical factors like a Holocaust, a civil war, famine, etc. And they were looking at how something that can span a nation ultimately impacts individuals. And this study goes so far as to talk about the epigenetic regulation of the HPA axis. So they're talking about genes essentially being turned on and off based on these broader socio-political experiences. And the illustration does a great job for me because it highlights what I'm aiming for here, which is to bring together all these pieces. And like I was saying at the beginning, to bridge the gaps between modes of understanding. And so here we have that example of really what shows up in the clinical setting is that we, they go generation 1, 2, 3 at the bottom of that slide. Those are the individuals that show up. But behind those individuals, there's such a broad context of factors. And the more that we can be aware of that, the better chance we have of being effective in our treatment. We can understand more about who this person is that's sitting in front of us. We can understand more about where they're coming from. We can understand more about how to maybe appeal to the family so that our chances as a whole improve. So I think, all of this, I know I bounce around a lot and I'm talking about history and genetics and, I kind of geek out. I love this stuff. But it's exciting because all of this is information that's going to help us be better. And as long as we can continue to improve and grow in our understanding, the more people that don't have to suffer from this stuff. And that's a tremendous feeling. And so I hope, out of anything, that's some of what folks take away from this is that we're at this really, really special place working in this field to be of value and to take from all of these different disciplines and fields of study and bring these things together to make some real change occur. So I'm gonna open it up, I guess, to questions here. Anybody that stuck around for the full session, hats off to you. I hope it was of some help and value for you. Thank you very much.
Yeah, I mean, and great job. And, jokes aside, we actually, the vast majority of folks that have been here the entire time. So I know it's
That's great. Thank you. Yeah,
it's
no, really, thank you. Thank you.
and it's a difficult format when you can't see everybody and engage, and unfortunately there's just too many people to do it that way. But great job. So we have had multiple people ask if you are comfortable making your slides available.
Yeah, absolutely. And I have, I threw together some citations too. They might not line, just so anybody knows, they might not line up perfectly with the slides, but I tried. So that's there as well. And I'd be happy I just send them to you, Tom, or Caitlin, if that's okay.
Yeah, and we'll circulate it to everyone that is registered and has attended, and thank you for
Yeah.
that.
Yeah, absolutely. Yeah, absolutely.
So there's a question. So can you offer any suggestions regarding how clinicians can better relate to symptoms of racial trauma in our clients, given the current season of our country's history?
Yeah, I think it's a great question. And, it's interesting like this. So this presentation definitely, it came up, or I started working on it in 2019, obviously before, everything that's been going on over the past, 6 to 8 months. I think this the complex trauma lens applies. We're talking about long-term intergenerational factors that show up in a variety of ways. And so I think obviously, level of cultural competence and doing your work in that area is important. But I feel like the relevance of that complex trauma lens is that it does address a lot of what's been talked about in this country. It's not, again, it's not like this isn't new. It's just that it's being talked about is new, right? So like everybody's, willingness to be aware, it has increased, but these are factors that, have been going on for centuries. So I hope that helps, answers the question. So
Thanks, Alex. There's one person that's just asking if you had a link regarding the epigenetic research that you mentioned.
Yeah, I can definitely look. I can definitely look for it. So one thing about that is that a couple of years ago, there's a big, kind of like a big story. I don't know, a big story relative. But there's a story out about epigenetics and trauma, and basically saying that it is a thing. And that, my understanding from what I see, is that stance has been walked back some, especially in terms of humans. I think we see it, or there's maybe more concrete evidence of the epigenetic factors in other mammals, maybe even in rats. But I don't think there's super clear-cut agreement on the epigenetic component of trauma in humans. I'd be happy to dig around though and find some of what I use, and I can include it or make sure to have it on the citation page of the slide. But it's interesting, and I keep an eye out on it because it's going to for sure inform a lot of our understanding and how we do treatment as well.
Do you have any suggestions? a little echo there. Any suggestions for working with people in substance abuse group setting with past trauma and strong personality disorder traits?
The biggest suggestion would be practice as much group work as possible, and then the big one, the real one, is do your own work. So understand what family system role you're taking on when you enter into that group. Not just that you're not just a therapist. Well, you are, but you're not. Unconsciously, you're going to be triggered by what other people are doing and saying. So doing your own work and having an understanding of some of those dynamics and responses is the most valuable thing you could do. I mean, probably beyond any kind of like training, right? Professional training, doing your own therapy. That's gonna be your best teacher. And then combining that with good supervision, consultation, and then as much group work as you can do. I mean, just do as many groups as you practice and grind and work with difficult people and learn how to deal with your own discomfort. And yeah, that's my suggestion.
And I just gotta like jump in real quick and say that the words like trauma informed care and trauma, they get thrown around a lot right now. It's become marketing terminology.
Yep.
More so than facility practice or clinical practice. And the reality is truly being trauma informed or providing trauma specific care opens, I mean, this happened with me and it's happened with our team. It opens you up to an understanding of personality disorders and working with individuals that are struggling on that level that it's very different from the training that we got 20 years ago and what have you.
Yeah, that's a great point, man. It's a great point. I mean, a lot, and that was my experience, was a lot of the terms that were sort of, they were marketable, and as they should be if properly understood and put into practice. But yeah, when you really sort of dig in and work to develop a more thorough understanding of what that actually means, it's super enlightening. And it does, it shifts the framework that you're able to work through, and it shifts the way that you view substance abuse issues. And yeah, it's a paradigm shift, and it's something that I think we see is continuing to happen for the better. So I'm excited to be where we are and doing what we do, because I think there is so much room for really cool stuff and a lot of growth. Yeah.
I agree 100%. I mean, I think that this is, one of the kind of leading edges of real kind of growth in our field. This is, I think, one of the places where the most impact can be had and outcomes improved in,
Yes.
decades of our work.
Yeah.
Robert Castle, just to say, he's helping, I think, with the epigenetics information. So he did say that Rachel Yehuda is the researcher who drew attention with a small sample of 32 subjects. There's a Wikipedia summary. I can't post the link, but there's he also, I think a good Google search will find a link to, research
Yes.
on that as well.
Yep, for sure. For sure.
Well, we are really at a place where we are out of time, unfortunately. I see some questions still coming in. I'm sorry I'm not going to have a chance to get to those final ones. Alex, again, great job. Thank you so much for doing a second talk and for doing, a 2-hour version in this deep dive. It's great to hear. It was informative for me as well. As a a reminder for the rest of you, please watch out for an email following the conclusion of this webinar with a link to complete the evaluation for CE credits. Also, save the date for Thursday, October 2nd, as we welcome our next speaker, Anita Gadia-Smith, who will be speaking on the topic of growth and recovery. We hope to have CEs for that as well. Those are in process. We will let you know if and when those are confirmed. In the meantime, if you need anything or have any questions regarding the organization sponsoring this event, please reach out to myself at Encore Outpatient Services, Mallory Schwartzman at Maryland Addiction Recovery, Jess Ayer, who represents Caron Treatment Centers in Maryland, and James Flencha, who represents Caron Treatment Centers in the state of Virginia and the District of Columbia. Thanks again, everybody, and you have a wonderful rest of your day. And thank you, Alex.
Awesome. Thank you guys so much. Bye.